Okay, you're good to go. Okay, you're good to go.
Hello everyone, sorry for the delay, but welcome to another Fresh Dental Shadowing session. Today with us we have an Oral Maxillofacial Pathology Resident, Dr. Laurel Henderson. So whenever you're ready, you can begin presenting.
Okay, thank you, Carolina. So my name is Dr. Laurel Henderson. I am not only an oral maxillofacial pathology resident, but I also have two additional specialties that I'm interested in and that I've done education in oral facial pain and oral medicine. So let's talk about what those are, who I am, and what I do every day. So we're going to be talking in three parts about my journey to triple specialization. We'll go over some case exemplars, and then we'll talk about some words of wisdom, especially for women in dentistry and people who want to follow their dreams like me. So who am I? My name is Laurel Henderson. I am a previous Miss 18, and I do a lot of community service, and I like public speaking, and I like talking about my specialties because they're very niche and not many people know about them, or not everybody has met all three of these specialties in dental school. My background essentially is that my mom is a dentist. I'm from Southern California. I always thought I wanted to be an orthodontist, but while I was in dental school, I got really sick, and I realized that there is a whole medical side to dentistry that I've been very interested in. I mean, when I was laid up on bed rest after having surgery, all I did was binge watch Grey's Anatomy shows, and I realized that I wanted to run around a hospital and make out with sexy doctors in on-call rooms and live the fabulous on-call doctor lifestyle, which I wouldn't have as an orthodontist. So I just started kind of scratching that itch of seeing how medical I could push my career. And I found something I think is a really good fit for me. So how did I choose my three specialties? Well, it was a very natural process. When I was at USC, we had a combined oral facial pain and oral medicine clinic. So I was able to shadow patients who had conditions that you can't really see, pain conditions, and conditions you can see, like lesions and cancers and infections, things like that. And I realized that the kinds of doctors that worked there were very different from other kinds of dentists, and that the time was particularly spent in asking questions, taking a really good history, doing the best head and neck exam you've ever seen in your entire life. It's like the best massage you've ever seen. Every patient had a very thorough workup of their medical history, their social history. And then we took all of that information together and we decided whether we want to do additional tests, like doing laboratory tests, blood values, doing a biopsy of tissue, or just going and starting treatment immediately. And I like the idea that I can not only diagnose but treat these complex medical conditions. So these are my mentors at USC that really started me. The guy on the left is Dr. Parrish. He's a legend at USC. He's an oral pathologist who is very clinically oriented. So he does practice oral medicine. And then the woman to my left or right when I was in the picture, her name is Dr. Audrey Boros, and she is a oral pathologist who works only in microscopy. And they brought me up and they made me who I am. So what are the three specialties? Oral facial pain, which was my first specialty, is kind of the equivalent of being like a neurologist for the mouth. So we work with headache pain, we work with jaw joint pain, we work with specific nerve pains related to injuries. Like if you get hit in the head and you have lasting injury after that, like the injury pain after that, I can work with that. We also do sleep medicine, so people who have sleep apnea, snoring, sleep disordered breathing, I do that. And then a lot of the jaw joint issues that are complex and too difficult for general dentists to do, I can also manage that. It's a lot of psychiatry too. It's patients who are medically complex who have mental health conditions. They also have more chronic pain conditions. So we have really good rapport with our patients where we talk about the hard things, the stress, the trauma, and we really try to get to the cause of their pain, because sometimes it's organic and sometimes it's psychiatric. And it's really satisfying to give them a place where they feel comfortable to talk about those conditions. Oral medicine is what I think of as a dermatologist of the mouth. So anybody who has peeling gums or they have some sort of lump or bump, anything that you can see in the mouth versus the non-seed oral facial oral facial pain conditions, the oral medicine doctor treats them clinically. So we decide where to take a biopsy, we do the biopsy surgery, we send that to the oral pathologist, and then maybe we'll start initiating treatment ahead of time. So we might order steroids or an antifungal, or we might decide to do a whole blood panel workout because we're excited about some sort of infectious disease. It's a very medical profession. Obviously, the name says oral medicine. And then finally, oral maxillofacial pathology, which is what I'm in right now, is very much like medical pathology. So I'm currently in between the laundry room and the basement, the laundry room and the morgue in the basement of my hospital. We're in a room with a microscope, and we look at pieces of tissue underneath the microscope. And not only do we look at the tissue underneath the microscope, but we also order additional stains, additional genetic tests, things like that. So it's very science-based, very biology-based. I would just recommend to anybody who is trying to specialize or choose what they want to do after dental school is think about what really brings you happiness. Try not to think about money so much. Sure, obviously, like work-life balance is important, but you have to think day-to-day tasks every day, like the tedium of every day. A lot of people talk about how they don't like working with facial pain patients because they quote unquote complain all the time or they never get better. And I think that those are the best kinds of patients because they're people who are really scared, and you can give them a really easy, good diagnosis just by having a good conversation with them. I love that. I never have to get out injections or scalpels or anything like that. I can have a good conversation and make them feel better. Versus like, say, oral pathology. Some people really love being their biggest introvert self and sitting alone in a room and looking at slides and getting lost in the beautiful pictures. But maybe, if you're a people person, that wouldn't work best for you. So you really want to think about what the actual tasks are every day and what the patients are like, and if you enjoy that or not. Particularly in the field of oral pathology, we have people who are on the autism spectrum who are incredibly gifted and talented individuals. They have these supercomputer brains, maybe not necessarily the same social skills that you're used to working with in the world of dentistry. And maybe that would be an uncomfortable work environment for you. Or maybe you'd love it because you think that these people are really intelligent. You can learn a lot from them. You just have to figure out what works best for you. I like many different things. That's why I have 3 different specialties. And I also like to think about, how can I put myself into this specialty? Do they have room for me to shape it and create something and build something? Or are they kind of like an old boys club that doesn't really want anybody to come in? For me, I really like the idea that I can share my own spin on things and build a new world and try to advocate for patients in a new way. And I think these new specialties, specifically oral facial pain and oral medicine, which are the 2 most recently accepted ADA specialties, have room for growth and for enthusiastic young people like myself to help change the face of the profession in total. So I would just also say to people who think that they are not good enough or not smart enough to go into specialties, particularly some specialties, they say it's way too hard, like surgery or pathology or whatever. I think that you just have to give yourself time. If you gave yourself a flashcard of a disease every single day for 3 years, you're eventually going to learn the disease. And although I might not have felt like I was incredible when I was in dental school, I've gone really far, and it's just because I put the time in and I have repetition now, and I can feel comfortable and confident in my skills. So, I started at USC. I now am in New York doing training on Long Island at the Long Island Jewish Medical Center. And now starting literally on Monday, I will do my 3rd specialty at Harvard Brigham and Women's Hospital in oral medicine. So in total, that would be 8 years worth of residency, which is a lot. And as far as I know, I'm the only person in the country and maybe in the world who has done all 3 of these specialties. And I'm really happy about it. I'm really excited about it. And hopefully I can enlighten to people that there are really fun specialties out there. Application process was pretty simple. It was basically, they're less competitive specialties. So you're not going against 150 different people for each spot. It's going to be like you are going against 10 people. But typically these are more quote unquote international specialties. So they have doctors who already have PhDs in pathology from, other countries, and they're applying, and they may be older than you and more experienced than you. And so you just have to bring your own skill set to the table and see if you're the right fit. My interview for Harvard was one of the hardest interviews I've ever had in my entire life. I was given, this is of course COVID time, so I wasn't there in person, but I was online. And in order to kind of give us like an even playing field, so it's not just the person with the best English or the best interviewing skills, but the person who is best fit for the job, they asked us to write 13 essays during the course of our interview. So in addition to talking to all the residents and talking to the faculty, we had to be completing essays. And the essays were evidence-based essays. You had to cite your sources, and they weren't just science stuff. It was like, tell me about the disparities, racial disparities in cancer care in the United States. They care about the kind of person you are. They would also ask, like, how would you treat this patient with a clotting disease? How would you treat them, and what are your treatment modifications? So it was really nice that they obviously cared about giving an equitable chance to everybody. Didn't matter if you're from the United States or from outside, but it was a lot of work. So just know that they might do some of that in the like post-COVID era. They might decide to do more of these like virtual tests. And when I interviewed for UPenn for oral medicine, I also had a multiple choice exam. So, this is the new thing now. You're going to have to come in paired. But certainly the most important things on the application process is showing that you have prior interest. You have a real passion and a real reason to be there, because these are very time consuming and energy and soul consuming professions. If you're not really in it, it's going to feel like torture. So they want to make sure that you're in your personal statement, you have a really compelling reason to be in there. For me, for oral facial pain, it was because I was sick and because I have a lot of mental health conditions in my family. I've had family members die from suicide, and I want to help people and prevent any loss of life or loss of happiness in the future. For oral medicine, again, it was that seeing beautiful disease and realizing, like, I love disease. I want to get in the mouth, and I want to help people with medical conditions like mine find peace. And then for oral pathology, it's like, I just want to be that person that is like a walking bookcase. I just have a passion for knowledge. But if you have a real burning reason to go into a specialty, that should be in your personal statement. I would say that your letters of recommendation should be very personal letters. They should not be from somebody who doesn't know you. They should be from people who would, put their reputation on the line for you. Say, like, I'm going to send this letter, I'm going to call them up, I'm going to bug them. I want you to get in. I'm going to do everything. I'll send them chocolates. I don't care. You got to find those people. And whether or not they're in that specialty, like, you don't have to necessarily have all oral pathologists write letters for you. I had a person who was, my group practice director in dental school, who just knew me as a general dentist student, but she knew that I was very interested in disease and lesions, and she tried to communicate that effectively in my personal statement. All of these helped build a strong application for me, and they'll probably help you too. Just make sure that passion comes across. And then my residency experience, each of them have been different. At USC, it was a 2-year program, and it was combined oral facial pain and oral medicine. It was a very international program, and I was the only American resident in the program, and that was wonderful. I got to learn a lot from other people. My co-residents had additional training. We had a prosthodontist who was doing oral facial pain. We had a person who did surgery and was doing oral facial pain. We had a person who did an AEGD and was doing oral facial pain, and we had a person who did oral facial pain in Korea and was doing oral facial pain again. So I was definitely the least qualified person there, but I got to learn a lot from my co-residents and grow with them. And it was a lot of work. I mean, we had classes, we had didactics. We would go on rotations at the hospital, at Keck Hospital. We did 6-week rotations in neurology, physical therapy. We did pain management, sleep medicine, rheumatology, and there was one more. Oh no, you don't need to know all that. Oral pathology is very much about looking at the microscope, being underneath the microscope. And the time is really not spent with dentists or with patients, but more with general pathologists. So you are regarded as a medical colleague and you consult on medical cases. So I have signed out thyroids, I sign out sinus masses, I sign out ear masses and eye masses, things like that. And it's a lot of self-study time. We are left alone without adult supervision with slides and a textbook and said, teach yourself. And that doesn't work for everybody. But it's really lovely. And then style, I'm going to get a pager. I'm going to have a trauma call. I'm going to have dental call. I'm going to work with medically complex patients, with children who are getting bone marrow transplants, people who are undergoing cancer therapy. folks that are really, really sick. The sickest of sick people go to Harvard. So that's what I'll get to see. And hopefully the grossest diseases, because that's what I love. All right, so let's go to some cases now. This is me playing TV doctor. That's one of my other goals in life, is to be a professional TV doctor. I have a master's degree in health and strategic communication, and I'm very passionate about putting accurate health messages in the public, which we all know in the era of COVID is really important. Having health messages that are accurate and understandable to all walks of life are really, really helpful. So, if anybody wants a dentist on TV, I can be that person for you. So our first oral medicine case is a 6-year-old male. His medical history is significant for autism spectrum disorder and anemia. And he has a recent development of bilateral joint pain, bruising, and hemorrhagic gingivitis. This is what his oral cavity looked like. You can see that his gingiva is very inflamed, it's swollen, it's red, it's bleedy. It looks really terrible. It looks like he's chomping on it quite a bit. And here are his lower limbs. You can see that the knees are strikingly large compared to the lower shin and the thigh. And this child actually was not ambulating, was not walking. The child also has a very limited diet. Disorder have limited diets because a lot of tastes and textures are not pleasing to them. They're actually too many senses for them. So this child was living on water, bread, and pudding. And this was a case of scurvy, scorbutic gingivitis. So this is what we typically think of with like pirates or like old-timey stuff, and it still exists. If you don't have vitamin C in your diet, you can have a breakdown of the connective tissues, and especially the capillaries that are in your connective tissue, the connective tissue capillaries. So you can have bleeding, you can have changes in the skin, like little tiny dot bleeding. On the lower leg, you can get coiled hairs. You can get in the mouth, that again, fragility of the gums, and you can have breakdown of the connective tissue in the joints as well. But one of my favorite things about this patient is that they were treated by incorporating cheese pizza into their diet. So a little bit of tomato sauce was enough to cure this patient. That's all you need. You need your dietary requirements. Okay, this next patient is a 13-month-old male with behavior suspicious for tolerance to pain. I'm sorry for that typo there, tolerance to pain. So that means that he can withstand pain. This is this little kiddo's tongue, and you can see that there's ulcerations bilaterally on the tongue. It has loss of papilla in those areas, and it has kind of the fibrinopurulent membrane, that kind of like ulcery white-yellow membrane. This is from his teeth chomping on it. And you can see how worn down his teeth are in the anterior. You can see this would be very, very painful for almost anybody else, but this child is just chomping away. You also see the cracking of the lips going on. I don't know. Can you guys see my arrow? Hopefully you can.
Yes, we can.
Okay, fabulous. All right. And then this is this child's finger as well. So this child is putting their finger in the mouth and chomping away at it as well. So all of these signs, particularly in a young person, are concerning for pain tolerance syndromes. One of the more commonly noticed pain tolerance syndrome is autism spectrum disorder. We call this finding in the mouth where you have self-injurious behavior that is not healing because it continues to happen. It's called riga fede. Other kinds of pain tolerance syndromes include Riley-Day syndrome, familial dysautonomia syndrome, which are kind of sisters. But essentially, the child should be worked up for further disease to make sure that we're not missing something else. All right, next patient is a 56-year-old male patient. He presents to his general dental clinic in our hospital for his annual evaluation. And our service was consulted for quote unquote healing gums. Oh, and I don't know if anybody is squeamish, but there's gonna be a lot of gross photos. So you might wanna log off now because it's gonna be gross, but I love it and I hope you like it too. So this is the patient as we saw him, and you can see this area that looks very thin and like it's almost peeling off here. You can also see this kind of corrugated texture, maybe a little bit of thickening, maybe those are peeling as well. And so as we do, we got kind of curious about it. We're like, can we make it peel more? So we tried, and yes, it does peel more. And on further questioning of this patient, he states that in the era of COVID, he was really worried about just keeping his mouth clean. And he decided that the best way to keep his mouth clean was to rinse with rubbing alcohol. So this is what happens if you put rubbing alcohol in your mouth. It's a chemical burn from rubbing alcohol. It's very dangerous to swallow it as well. It's a poison, but it can cause significant damage to the gum tissue. And it's pretty bad looking, and we told him to stop that. And there are other ways to avoid COVID, more effective ways to avoid COVID. All right, the next one is a 31-year-old Ecuadorian male who presented to the emergency department and subsequently admitted due to suspicions of tuberculosis. The patient is HIV positive and non-compliant with his medications due to the adverse effects. Currently, the CD4 is 49 and the viral load is 186,000. So this is pretty fulminant HIV infection. So there's this nodule on the neck that is tender, and it is indurating at the time, so it's almost like breaking through the surface. His nose has kind of these flat red purple patches. His mouth also has a little bit of those purple patches. There's a little bit of shaggy white on the side of his tongue, and there seems to be redness on the hard palate. And all of these, if you've learned about HIV, really follow what you would expect for a patient who is immunocompromised. So some further tests were done to determine if this patient has tuberculosis or has other HIV-associated diseases. So on the right, you can see that this is a special stain for fungus, and this is a fungal hyphus here. And this is a sputum culture here on the left. So this patient has uncontrolled HIV with primary tuberculosis that was confirmed positive on the sputum, the AFB sputum, which is the picture on the left, you can see here. And the cervical TB lymphadenitis, known as scrofula, was confirmed with cytology. So they put a needle in his neck and they were able to see that there is TB in a lymph node. Kaposi sarcoma was present on the nose, the lip, and the palate, but not biopsy because we already know that he has HIV and it's uncontrolled. Kaposi sarcoma is a type of connective tissue cancer. It's specifically related to the blood vessels, so it kind of looks like flat pepperonis on people, and it's can be in the mouth or it can be on the skin. Oral hairy leukoplakia was that side of the tongue area, and it was kind of shaggy white looking, and that's associated with Epstein-Barr virus in patients who have HIV. And then Candida is a yeast infection that we saw on the palate of that patient. And again, these are all kind of like commensal organisms that, or not commensal, opportunistic organisms that take advantage of a host that is immunocompromised. All right, next one. This is really gross. Prepare yourselves. This is a 30-year-old male that I was able to see. He has his chief complaint of lip pain, swelling, and ulceration for 1 week. He has a history of laser hair removal procedure on his beard 1 week prior. And he takes medications for hypertension, and he has neurofibromatosis. Interestingly enough, his brother is the dermatologist who did the beard treatment for him, the laser treatment. And the brother states that he thought he saw like a little pimple on his brother's chin and tried to squeeze it a little bit, thinking, maybe it'll just go away. But the lips still kept on getting more painful. So, the brother thought maybe it's some sort of infection, maybe it's bacterial, maybe it's viral, I don't know. But they tried the patient with antibacterials like Augmentin and antivirals like Valtrex and prednisone just to get the pain and the swelling down, and acetaminophen for pain as well. And the pain, for the patient is a 9 out of 10 or 9 to 7 out of 5 out of 10, which is not great. We need to get it better. So this is how I saw the patient. It's a big chunky lip. It looks like a hot dog that's losing its skin. And this guy, obviously, he can't close his mouth. This looks terrible. It has ulceration on it. It is not a typical presentation of herpes virus at all. Herpes is typically on the vermilion if it's secondary herpes like herpes labialis, or if it's primary herpes, it's going to be on the gingiva and in the oropharynx. This is what it looks like when the patient retracted his own lip, And you can see that there's this purulent exudate. It's like a sinus tract coming from the lip. You can also appreciate that there are areas where it looks like these bubbles of pus here underneath the surface. And if you remember from us talking in dental school about infections, if you see something that has like a yellow fluid coming out of it, that's a bacterial infection, not a viral infection. It could be fungal infection, that would be less likely. But since the patient was not responding well to the antibacterial medications that were given to him, we were concerned a little bit. We're like, maybe we need to explore this a little bit more. So over the next couple of hours when I talked to my attendings, it got worse. So you can see that it's starting to drain out of his chin down here where that brother thought he saw a pimple. And it starts really, really breaking apart, really, really bad. This is within this course of maybe 3 hours. It started draining a lot. And so the idea was to do an incision and drainage to try to get all of the pus out of the lip. And, the patient obviously is anesthetized for this. We're not doing this with him. He's awake for it, but his lip, we're not trying to make him feel bad. We also did a culture of the area. So we put like a little swab in the area trying to pick up the microorganisms to see if it was bacterial or fungal, if we could try to identify something so we could help give him the right medication. And you can see that there is really bad Factitious tracts. It's just breaking apart. And I'll be honest, if you're feeling gross right now, you are not the only one, because I actually passed out during this procedure. I've never really passed out during seeing somebody's lip get like oozed like that. Like, I love gross stuff, but I felt really embarrassed because I had to sit down, and the patient's like, oh my gosh, like, am I okay? Like, my doctors are passing out right now, but we're all good. So here's another one coming from the skin side all the way through. So the lip is just breaking apart trying to get this infection out. So our diagnosis is folliculitis. So a hair follicle got inflamed and infected from the bacteria on the skin. We did a treatment of incision and drainage and culture, and the final diagnosis came back of folliculitis and MRSA, or methicillin-resistant Staphylococcus aureus, which I'm sure you've heard of before. It's kind of a big bad guy. And that's why it wasn't responding to the medications we had given beforehand. So he was given IV antibiotics, and the incision and drainage helped speed along the process. So the next day I saw him, he looked a lot better. You can see that the healing, he's obviously very crusty, but the swelling is down quite a bit. He doesn't have that breaking of the lip anymore. He's just doing a lot better. Okay. Oh, and now moving from oral medicine, we're doing oral pathology. So oral pathology, again, is underneath the microscope. And these are little photos that I've taken with my iPhone up to the little ocular of the microscope, just because I think things look pretty. If you like pretty patterns, or if you like pretty colors, oral pathology might be good for you. For me, I love quote unquote cloud gazing at the microscope, looking for things that don't look like body. They just look like pretty pictures. So this is thyroid, normal thyroid, but it looked like a pretty heart for me, which I liked. Here is a papilloma, and it kind of looks like a bunny if you kind of look at it sideways. Here are Russell bodies, and I think it looks like a hibiscus flower. All of these look like little tiny hibiscus flowers. This is in a pleomorphic adenoma. This looks like a nose to me. You see the bridge and the tip and the nostrils. And then this one is just because I'm a child. This looks like a penis to me, and I thought that was really, really funny. So here's another part of what we do. We gross specimens. So we get specimens from the operating room in a jar, and they say, okay, I cut this out. Please tell me where the cancer is. Did I get all of the cancer? And so this is a patient who had hemimandibulectomy, or a cancer that was in his parotid gland. So you can see there's skin on the outside, there's muscle, there's parotid gland, and then we're going, underneath that is your jawbone. So you have your coronoid process here and your condyle, and this is kind of the anterior portion of the mandible. And so we get the absolute pleasure of cutting these on the bone saw and putting them in acid to decalcify the bone. It's great fun. You can see that this is a large specimen, and from another angle you can see that it was the top and the bottom, and there's even teeth in here. And so you could open and close it like a mouth, which is the grossest thing in the world. But again, how lucky are we to see that? Nobody sees this. This is the craziest, wildest thing. So we get to put ink on it and tell you, okay, this is the posterior margin, this is the anterior margin. Are these clean? Are they not? Did you get all of the cancer? It's a very important role to play, and it's kind of fun. So this is an oral pathology case. It's a 74-year-old female. This patient has heavy granulation tissue and very sudden bone loss on teeth number 29 and 30. The dentist curetted the area and, quote, scraped off white plaque. And the clinician's differential diagnosis was verrucous carcinoma versus squamous cell carcinoma versus aggressive periodontal disease. So essentially they were worried that there's something going on in the teeth. We don't know, but we'll just scrape it off. And then eventually, after a while, they submitted tissue to us. So I have some radiographs. So you can see this initial radiograph. You have teeth 29 and 30 right in the frame there, and then 31 behind. You see a little bit of a vertical defect here, but it's not huge. They just kind of scraped that area. Let me move this aside. You can see not long afterwards, I should say a long while afterwards, it was 3 years, let's be honest, it was a long time. We have a pretty significant bony defect on the mesial of number 30, and there's kind of this soft tissue swelling in the area. Like, it doesn't look good. If I was the doctor then, I would have sent this tissue in a bottle to an expert. But they didn't. They waited, and 4 months later, it got really big. You can see on pictures 3A and 3B that this is almost the entire mesial portion of tooth number 30 and the entire distal of number 29. So both of these teeth had to come out. We had to figure out what was going on, because this is a pretty aggressive disease. I think you would agree with that. Like 4 months, 3 months, essentially, this patient's losing so much tissue. It's not good. Oopsies. Okay, there we go. So this is the panoramic radiograph, also taken at that same time, and you can see that this is an extensive lesion that really cups out the bone, and it's very worrisome, especially since it was kind of normal looking beforehand. And so this is our histology. This is our bread and butter, what we look at every single day, pink and purple. So our normal tissue typically is this kind of pink color on top with these little like zippers going down, call that the reedy ridges and the connective tissue papillae. And that's how the top layer and the bottom layer stay together. And it should be kind of flat and regular and just look like a little zipper. And they should stay separate from each other. But in this case, you can see that there's kind of drop off of this top layer. And that's not a good sign. That's actually a very bad sign. That's kind of like invasion. Cancer invades into the deeper parts. So this is squamous cell carcinoma, and squamous cell is a problem with these top flat cells. Squamous means flat. So this kind of cancer, carcinoma, is of the flat cells, the squamous cells. And they create certain structures called squamous eddies or keratin pearls. And there's a lot of inflammation in the background. So I'll show you those ugly cells. There's also going to be they look like mutant cells. Like they're just bad looking. So like their nuclei are dark and large, they're ugly, they're not behaving themselves, and we do not like how these are dropping off. I'll show you another one. So these are your squamous eddies. These squamous cells are like making a ball. You can see these ugly big nuclei here. This is all bad cancer. And this likes to swirl around nerves, and when it goes into the nerves and the blood vessels, that's how it metastasizes to other areas like lymph nodes or to lung, other body parts. Again, there's a little keratin pearl, squamous eddy, ugly, ugly cells, lots of inflammation in the background. The body's trying to fight it, but it can't. It's just not strong enough of a response. It's not taking down this whole cancer process. So the diagnosis was right mandibular gingiva, biopsy, squamous cell carcinoma, well differentiated. So well differentiated just means that you can identify it easily. If it's poorly differentiated, it's really hard to diagnose, and it's like really bad cancer. So this is, it's not a good cancer. None of them are good, but it could be worse. All right, so let's do, this one's another big gross one. Prepare yourselves. We have a 17-year-old Liberian male. A United States oral surgeon heard about this child's condition when he was in Liberia doing missionary work. He brought him to New York for treatment of a gigantic mandibular lesion. So let's see. This is the big boy. This is a fungating mass. It's an expansion of the mandible. You can see, obviously, there's hemorrhage. This child is having difficulty breathing, difficulty feeding himself. It's really, really bad. We have some images. You can see that this has completely twisted and destroyed the mandible. So you can see these are a couple of teeth here that have been displaced. You can see that the child is on the nasopharyngeal tube, nasogastric tube. So he's essentially being tube fed to sustain his life. Here's another picture. This is our lateral view. And you can see that this is a pretty thick lesion. It has a, so let's go over just basics of reading our images. So this is a CT scan, okay? And CT scans are gonna have, we're gonna have white for your bone, so bright white bone. And then we're going to have air spaces less dense are going to be black, and then fluids, which are kind of a mixed density, are kind of a gray color. So you can see the skull is white, the teeth are white, this whole mass is white. The air in the sinuses is black, the brain is gray. So there are some areas that are a little bit less dense, and then there's some areas that are like almost air. So it's kind of like a crackly appearance almost. Almost like snowflakes, or it's condensing, it's getting more dense as you go through it. And so this is the big bad specimen. And yes, we did get to see this. It's like this big in person. It's like gigantic. And we did get to take it to the bone saw, and did get to tell them what was going on with it. And although I wish it was, well, not wish, but everybody kind of wishes that it was like a crazy cancer. It actually wasn't. It was a benign process. Thank God for this patient. Good news for this patient. So this is the histology. So this bright pink color is the bone. And you can see that this is kind of irregular bone here, right? It doesn't have the same shape or color. It doesn't have the beautiful laminations. It's kind of like little clusters or clumps. We think of these as like sympomatoid. Sympomatoid means like little spicules or spherules. And then it's kind of in a fibrous background. So that kind of like light blue, light pink, those are fibrous tissue pieces. And so it's both ossifying and fibrous, and it's in a child. So we called it juvenile ossifying fibroma. So again, very fibrous. These are some cells that make bone here. And juvenile ossifying fibroma, benign but very aggressive, and if not treated, it can be it can cause death, because the airway or the ability to feed is not available anymore. All right, so now we're moving to my third specialty. So now we're going to orofacial pain. So I have a 23-year-old medically healthy female who has a chief complaint of, I studied abroad in Spain this summer and got bad sores all over my gums. My doctor prescribed me antiviral medication and the lesions went away, but now my gums are hurting really badly and I'm starting to get small rashes again. So this is a picture that the patient sent to me. When I saw her initially, I didn't see anything in the mouth. And every time I would see this patient, it was kind of interesting because she had been in so much pain, and she was kind of the same like age as me, maybe like a year or two younger than me. And I really, really wanted to help her. I mean, that's the goal, is try to make everybody feel better. But every time I saw her, I didn't see anything in her mouth. And then she'd have these pictures that would have little like scratch marks on them, or like little like lesions, like maybe they were a pimple, maybe whatever it is, just something going on. So we tried, running lots of blood panels on her, trying to figure out if there's like an autoimmune processor missing. Nothing really came up, but she was still in a lot of pain. We tried giving her some topical pain medications just to numb the area, because that's something that we do for certain neuropathic pain conditions. And it helped, but not really. And with this picture, my attending, so this is kind of later in the process, my attending kind of looked at me, and he's this guy who's been around for a long time. He's like, Laurel, have you ever thought, like, why is it healing so quickly? What things happen in the mouth that heal in the matter of 2 days, where she'll show you a picture on Saturday and you bring her in on Monday and it's gone again? Or what can happen? And he's like, Laurel, have you ever thought about the fact that like it may be self-injurious behavior? And I'd never really heard of that before, certainly not in dental school. And I think that that's not something that we talk about very much, of like when the patient's presentation to a dentist is actually psychiatric disease. How do we diagnose that? How do we send them to the right place? Because there are patients who will think like, hey, like I have something in my gums. There's a string in my gums, or there's little particles in my gums. You need to take them out. And, we'll do all of the appropriate tests. We'll try to believe the patient as much as possible. But if the evidence is not there, you have to start thinking about things that are non-organic based, non-bodily. So this is something called factitious disorder, meaning she's injuring herself. And the way that we describe it is we call it medically unexplained symptoms. So that's essentially when a person acts in a way that they consciously create the symptoms. They pick at themselves, or they injure themselves trying to find something that's wrong, and it's not a disease process of the body. It's more of mental health. So we aren't, mental health practitioners. We do send these patients to, mental health counseling, to psychology, sometimes in psychiatry, I should say. Sometimes it can be difficult to get these patients in the door because they really want the thing in their mouth taken care of. And so sometimes what we'll do is we'll write in the consultation note, we'll write for them to see a specialty called pain management. So pain management is the love child of anesthesia and psychiatry. And so there are these doctors who understand mental health conditions and pain conditions, and it just helps them get the care that they need better. And we use the term MUS, or medically unexplained symptoms, as kind of shorthand in that letter to say, like, hey, I think that this is something going on with the patient's mental health, not necessarily an organic process. So that's just something to put in your back pocket if you ever suspect something like that. Oops. All right. And I just want to remind you guys that my objective as an orofacial pain person is to believe people, particularly women, particularly people of color, people who are overweight, who are disabled, people who live underneath the poverty line. These people have historically been underserved by medicine. People don't believe them, and it is to their detriment. And people die because of this. There are studies that women who go to the emergency room with heart attacks are often told that they have panic attacks, and they don't have the proper tests run. They aren't believed, and there's undiagnosed heart attack that is the reason for their demise. So we need to be believing our patients, and we need to do due diligence. And I just really want to remind people that, the term crazy doesn't help anybody, because it takes all of the compassion out of the conversation. It just says that is something else, and I don't plan on understanding it. I'd rather use the phrase, this person is sick and they need medical help. And I'm a medical person and I want to help them. And maybe I can't in my specialty, but I can send them to somebody else who can medically help them. So just remember that, your compassion is really the hallmark of you as a doctor. And if you remove compassion from what you're doing and your empathy from what you're doing, you're really not a good doctor. You always have to put yourself in the patient's shoes, because their suffering is real. Whether or not it's psychological or physical, they're still suffering. And we have to relieve that suffering in one way or another. And this is just another, thing about, how women and young girls, oftentimes we are told that we are being dramatic or hysterical, when in fact we have pain, and our pain is serious and is real, and it's a serious ethical issue. And that's something that I feel very strongly about, is that, we need to treat everyone's pain the same and believe everybody the same. So here's another clinical case. We have a 73-year-old female. Her chief complaint is, ever since I got that sleep appliance, my tongue burns and I have a funny taste in my mouth. I think I'm allergic to the appliance. I stopped wearing it. She has a 2-day history of these symptoms after delivery of a special sleep appliance called a dorsal appliance. The patient called with her concern, and the patient's husband, who is an engineer, suspects that the monomer in the plastic is leaching out, giving her an allergic reaction. The patient went and saw her medical doctor, who suspects is Candida. And if you're anybody in dentistry, you understand that that's kind of an inside joke, because that's like the only phrase that they know about the oral cavity is like, oh, I think it's thrush. I think it's thrush. There are so many other things it could be, but every doctor seems to think that pain is thrush. It's typically not. The patient's medical history is a little bit complex. They have hypertension, GERD, sleep apnea, and back surgery. And so they have a lot of chronic pain. The patient takes a torvastatin, omeprazole, and tramadol for their back pain. So these are the two appliances. The patient initially had a TAP 3 appliance. She had this appliance for many years before she came and saw me in our clinic. She's been in the Orofacial pain clinic for many years. I'm looking at this going, this is not very good for your teeth. You're not biting on all of your teeth at the same time. Like, we could do better for you. Let's give you something a little bit better. So I made her a dorsal appliance. She already needed a new appliance. That one was broken down. It wasn't fitting anymore. We're going to make her a new, fancier appliance. And that's when all of these symptoms started. And that's a real important piece of information, because any big change to somebody's sleep or the way their mouth feels can trigger a chain of events. It can be very stressful for patients, especially if they don't like something, and maybe don't want to tell you that they don't like it, but they truly don't like it. That's very important to understand. So the patient's exam was unremarkable. The candida culture, which we performed just in our due diligence, was negative. And we placed the appliance in a pressure pot to try to finish the polymerization process. So there was no more monomer leaching. So she couldn't have an allergic reaction from it. That did not help her symptoms. None of these helped her symptoms. The assessment that we gave was something called burning mouth syndrome. And this is one of the most common conditions that we see. It's rampant, particularly in women who are pre, post, and perimenopausal, people who are going through very stressful lifetimes, people who have had major health changes. So in the era of COVID, we've had a lot of people come in with these feelings. It's a triad, either feeling of scalded sensation on their tongue and their nose and their mouth and their vulva. They can feel like they have a loss of taste, or their taste is wrong, like they have a metallic or bitter taste in their mouth. And then finally, they can feel like they have dryness in their mouth. But when you look inside, there's no dryness. It's actually quite moist. And this condition is not related to quote unquote disease. It's a change in the nerves. And there's a lot of theories why we have this change in the nerves, but essentially it's an atrophy of the nerves. And the nerves that are left over are hyperexcitable, screaming at these patients all the time. So it's a nerve confusion. You don't feel things properly. You don't taste properly. Things feel painful when they're not, and you feel dry when you're not. So what we did for this patient was we told her to discontinue use of that appliance that she clearly didn't like. We gave her the material safety data sheet just so she could feel good about knowing what was in that appliance. And if she wanted to go get allergy testing, she was absolutely encouraged to. We told her to discontinue the antifungal troches that her doctor gave her MD gave her, because she didn't have a candida infection. We prescribed a medication called clonazepam, which is typically used for patients who have anxiety. And this medication is actually, it locally acts on the nerves in the mouth, the taste buds. So the drug isn't actually swallowed. We crush it, we dissolve it in the water, we hold it in the mouth just for 3 minutes so it works locally, and then spit it out. So you don't get any of the psychological effects of it, you get the local effects, which is what these patients need. And we remade her appliance because that's the one she clearly liked, and that worked. That was the silver bullet. That finally helped the patient because she really wanted that. We changed her life in a way she didn't like, and she needed to be brought back, and her pain went down. So just think about those things a little bit. What patients are experiencing is real. You might not have heard of it before. And if you haven't, that's okay. Send to a specialist. They probably have. We can talk about this, but we probably don't have enough time. But just the idea of psychiatric disorders could have been there beforehand. Or they come on afterwards. It really doesn't matter. You still have to treat the pain that somebody is in, and you have to get to the root of the problem. A lot of people are stressed out. A lot of people have pain. They're a self-fulfilling prophecy. And, we talk about in the world of pain that physical injury doesn't matter unless you suffer. So if any of you are athletes and you know what it's like to push through a really hard set, like maybe you're running really fast and it doesn't feel good, but you don't mind it because you're doing something you've chosen to do, right? Or maybe a mom deciding that she's going to lift a car off her child. That's pushing through pain because she's decided to. Or maybe you've decided to stay up late because you're hanging out with your friends. It's your last night studying abroad and you want to have a last night fun time with your friends. That's not going to hurt as much as, say, staying up all night studying for your board exam. One has suffering, one doesn't. So pain is very relative, and it's determined by your expectations with pain. If you had a painful childhood, if you're expecting things to be traumatic or painful, you're going to be more easily excitable. If you have more hyperexcitable nerves because you have taken certain drugs, if you have a culture that encourages displaying pain and suffering behaviors, you may feel pain more. Other cultures are more like, oh, just walk it off or rub some dirt in it. Like not everybody socializes pain the same way. And again, we talk about the idea of, pain isn't just an injury. It is the patient's way of dealing with stress and the way that they take care of themselves. And one of my favorite quotes is, it is more important to know what type of individual has this disease rather than the type of disease the patient has. You really want to treat the patient, not the disease, because everybody's going to respond differently. So that was my case section, and we're going to wrap it up by just talking about what it's like to be a woman in dentistry. And I'm very grateful right now. You can see in this picture, I'm in a cohort of 4 female oral pathologists, and we have 1 male oral pathologist who just came in, but the 3 of us on the right over here, we're all co-residents, and we're all graduating this year. This is our 2nd year, Sarah Franklin, and this is our big boss, Dr. Fantasia. But the world is changing, and women are at the front of it, and you should be proud of yourself, and you should keep pushing, because we need more representation, and we need more women of color, and we need more gender fluid people and queer people. We need to expand what dentistry looks like. It's not just wrinkly old white men. I am a big proponent of telling people what your dreams are. I find that the more of my dreams come true, the more vocal I am, and the more people catch me working towards them. I never thought in a million years, if you asked me, 5 years ago, would I be going to Harvard? No, but I've told everybody that that's what I want to do. And people made it happen for me. I've told people that I wanted to be in pageants, I wanted to win things, and people helped make that happen for me. I think of it as like into what happens. So this is a picture on the left of me. I was like a photo shoot for a pageant thing, and I was feeling like going home, and the photographer's like, you're done with the photo shoot. Would you want to just come? We're going to go out in the marina real quickly. Would you like to enjoy it? And then we had a photo shoot on a boat, which would have never happened in my life any other way. And you just have to be open to the things that life will pass your way. There are times that I don't know if any of you guys are spiritual or religious or whatever, but I think that magic happens and life happens for you. And there are moments where like God gives you a little wink and say like, hey, I'm there for you. I'm making incredible things happen for you. This picture on the left is a pain conference that I went to where I just told my program at USC that like I wanted to be, one of my dreams was to be sent to go to conferences for free. I wanted to travel and get to go see conferences and just be like somebody who was learning and being part of education for free. And so they're like, great, why don't you go to this Napa pain conference? We'll take care of it for you. And they did. And then, while I was there, there was these special dinners going on. And I just asked if I could go. Like, I didn't even have a ticket. I just asked, like, hi, can I go to this vineyard dinner, which was very exclusive? And they're like, yeah, you seem nice. Go ahead. I think that a lot of times, especially as women, we don't ask for things. We assume that it's not going to work or it's going to be too hard or whatever. But like, I'm here to tell you, you can ask for things. Like, so let the universe surprise you. These last couple of years have been very dark and very scary and hard. And I hope that you don't lose your enthusiasm for life and your faith that good things happen. You guys are all dedicating your lives to higher purposes. And I just think that life really happens in your favor. You just have to look for the good and act in good ways, and karma will take care of the rest. So my closing for you is that the only certainty that ever has been or ever will be is that anything is possible, and you get to determine what that anything is. So if you guys have any questions, I'll open it up to questions now. Otherwise, thank you. You can reach me on my social media at Dr. Laurel, or you can email me. My email address, you'll just DM me and I'll give you my email address. I hope that was helpful to you all, and it was fun for me.
Thank you so much for all the motivation and sharing all your cases with us. So now we're going to move on to the Q&A section. I'll just ask a few questions because of time. But for the first one is, how do you deal with anxious patients, especially dealing with diseases during dental procedures?
So I think the first thing that you have to do is set the scene for them to have a good experience. So put yourself in the patient's shoes before they walk into the room. Make sure you look around the room, make sure that there's no clutter hanging around, make sure that you don't have instruments out in their eye range, make sure that everything is as clean and as visually appealing as possible. That's the first step. Second thing is, when the patient walks in, I don't touch them yet. I put the hand over my heart and say, "Hi, I'm Dr. Henderson. Nice to meet you." I show them my name tag so they can read my name. Very simple stuff. And then I immediately go wash my hands. And I show them in front of them my hot red hands. I did under hot water. If they have OCD, they're in good hands with me. Okay, this is a clean place to be. And then I have them, they're sitting down. We're talking, we're seeing, how they are today. And I make sure that our chairs are either level or the patient's chair is slightly above mine. So I'm never standing up. They are always in a position of power in the dental relationship. I'm there to listen. I'm not typing. I'm not writing notes unless they're very small notes. I'm there leaning in, listening intently, making sure that they know that I'm invested in them. Before I do anything, I explain verbally what I'm going to do. So I say, okay, "Hi, I'm a chief resident in oral pathology. I'm going to be doing your physical exam today and talking to you about what I think is going on in your mouth. But I have an attending, Dr. Kelsch, who's also going to see you today at the very end, and he's going to do basically the same thing all over again. So ask your questions. Let me know if anything bothers you. Make sure that we have a conversation going because I want to make sure you're feeling good." And then I start by telling them where I'm going to touch them. So if I'm going to touch them on the hand, I tell them, I'm checking muscle pain, I'm checking your fingernails, this is why I'm doing this. I like to touch the hand before I touch the neck because this is a vulnerable area. I do a head and neck exam on every single patient every single time. So it's always for me, touch the hand, touch the neck, and then change gloves so you don't have any makeup or oils or anything like that, and get inside the mouth. Okay, so they've had a good warm-up process before you're doing anything that makes them feel uncomfortable. And everything that I do, I'm narrating for them, and I'm telling them the process of, everything looks good. So I'm touching on the sides of your neck. I'm trying to feel the glands in your neck. They should feel soft and no tenderness, no lumps or bumps. I'm going to feel above your collarbones here. Everything is feeling normal. I'm going to feel behind your ears. All of your glands look normal. We're going to feel your thyroid. I'm going to have you swallow for me, please. No nodules, no enlargement. This all looks good. So everything that I'm doing, they understand why I'm doing it, and they know that, okay, this looks good. That's a little less anxiety. That's a little less anxiety. I tell them if I look in the high-risk cancer zones, okay, I'm going to look at the side of your tongue, the floor of your mouth. This is a high-risk cancer zone. Everything looks like normal, pink mucosa. There's no changes to the surface. I'm not concerned about that. So they know that I did a good job looking, and that they are going to be safe. So that's another thing that they're less worried about. I also make sure that we have a conversation about their stress and their anxiety before I start touching them. So every patient, I ask about stress in their life because everybody has some, and I just want to know where they are. And you'd be surprised what some people will tell you. Some people are like, "I had a really hard time getting here this morning. I have a child who is quadriplegic, and we had a really hard time getting breakfast in this morning." You're like, "I would have never known that beforehand. Oh my gosh. Okay, let's try to give you a good day today," or whatever it is. Those little details really matter for patients. And although it might not seem like a typical dental question to ask, everything's connected, right? If you have the stress, you're probably going to have jaw pain. So we're going to do extra checking of that. We're going to try and make it a really comfortable appointment for you. So I just try to, anticipate what a patient would be worried about. That's the biggest thing. And then the pacing of my voice is something that I do as well. So I try to, speak my little chipper self in the beginning, and then I really slow down at the end. And I think about what the diagnosis is and what the right course of action is And I'm just so happy that we've come to the right diagnosis and that they're going to feel better very soon. And today is going to be a great day and they're going to sleep really well tonight. And you can just see that everybody just kind of falls asleep a little bit compared to like my height. You know, that sort of stuff we don't really talk about that much, but it really, it helps you have a better opinion of patients, I think. Hopefully that answered that question.
Yes, I didn't know so many things went into making someone feel comfortable. Okay, so another question is, how important is mentorship in the dental field?
I think that mentorship in any field is good. I mean, as part of being a human, we get so much further than previous generations by learning from them. I find that it's very useful to have mentors that are peers, mentors that are just a little bit ahead of you, and then like the old timers. Peer mentors are like your friends, people who will tell you like their take on things, you know, and you hopefully have really smart, lovely friends and they'll inspire you to become who you are. Mentors that are a little bit ahead of you, you know, 5 years, 10 years ahead of you are obviously what people think of really when they think of mentors. And I found a lot of those when I was in dental school, but I also found them in undergrad as well. People who are interested in dentistry and like, hey, here are my scores on the DAT. Here's what I got. Like, I'll lay it all out on the line for you. Like, here's the good, the bad, and the ugly. Like, I accept you for the ugly, imperfect human that you are. You know, it just makes you feel a little bit less like you have to be perfect. Because I think like when mentors are supposed to be there to show you like how not to make the same mistakes that they did and how to go further than they did. And so hopefully they'll reveal to you the mistakes that they made and the things that were hard for them so that you feel like you're going to be okay. And obviously you want to have the old guy mentors because those are the ones that can really open the door for you. You know, if you really make friends with one of the presidents of the academy or something, you get them on your side and like, oh, I want you to be a speaker at the meeting this year or something, that opens the big career doors for you. That gets you the next level. So I think, yeah, having at least 3 mentors would be good for everybody.
And for the last question, if there's anything in the dental field that you could change, what would it be? And I know you've mentioned treating everyone's pain the same regardless of gender, but is there something else that you could change or would like to change?
I think the biggest thing that I would like to change is our reasons for. My mom's a dentist. She's a general dentist. And, you know, she's often complained that, you know, the way that insurance really dictates what things are done or how fast they're done. You know, everything is done to make $1. And I've really felt uncomfortable with that. I don't want to sell dentistry. I don't want to try to upsell people. I don't want to try to add on services or packages or whatever. That just doesn't sit well with my soul and what medicine is. You know, really taking care of people is. It shouldn't be about money. In my perfect world, money and medicine would never mix. Everybody would get the best. You know, that would be my favorite. So that's why I've really stuck to the more medical professions of dentistry. So I'm never selling anything. I'm only ever doing what is medically necessary for patients. And I really wish that my peers had the same value set, that, you know, instead of, you know, let's whittle every single tooth down to put crowns on so we can make $100,000 on a case. You know, let's think about what this patient actually needs to feel beautiful from the inside. You know, let's talk about the things that are actually healthy rather than like, oh, you know, this particular toothbrush company is sponsoring me right now. You know, is that the healthiest toothbrush or is it the one that you put in your mouth? Right? Like, that's the one my mom always talked to me about. Like, I'm not here to like promote a brand. I'm not here to make money off of things. I just want people to have good outcomes. And I know that that's, you know, there's nothing wrong with money per se, but I just realized that holds a lot of people back from seeing specialists like me because they can't afford their treatment from specialists, whether it's an orthodontist or whether it's orofacial pain. You know, there are a lot of orofacial pain people who don't accept insurance. And I just think that that's wrong. So that's I wish that the world didn't require that. I wish everybody had everything.
I agree. We should look for the interests of the patients first. So I wanted to thank you so much for your time and for being here with us today and giving all your advice. I loved your presentation.
Thank you. It was a pleasure to be here.
Thank you, everyone.